All right, so again, I'm Andrea Paulson. I'm Associate Medical Director for Greater Minnesota Clinics, and I'm one of the Pediatric Rehab Medicine physicians at Gillette. And so I get to talk to you today about spasticity management. So we're going to start by reviewing kind of what the definition of a contracture is, and then we're going to spend time going through definition of hypertonicity, spasticity, and dystonia specifically, and then spend the majority of the time talking about different ways to manage or treat spasticity, things like bracing and therapies, oral medications, injections, and surgical options. The two objectives for today are going to be for you guys to be able to define spasticity and to list different ways to manage it. So jumping right in, one of the most common areas of confusion that I see in the medical records is really contracture versus spasticity. And so I want to take just a minute really to discuss what a contracture is. And so you can see the images here, but contractures are the chronic loss of joint mobility that are caused by structural changes in non-bony tissue. So things like muscles, ligaments, and tendons. These develop when those tissues that are normally very elastic are going to be replaced by more inelastic tissues, which results in shortening and hardening of the tissues. Ultimately, that leads to rigidity. You're going to see joint deformity, and you're going to see loss of movement around the joint. So sort of stated another way, the contracture is the limitation in the passive range of motion of the joint that's secondary to shortening of those other periarticular connective tissues and muscles. Contractures tend to be the final common pathway for many different conditions. So most often we see contracture being the result of immobilization, but it can also be caused by muscle imbalance, by prolonged spasticity, by burns, and local trauma. Risk factors for contracture development include motor dysfunction, secondary to either hemiplegia or quadriplegia. You can see them secondary to hypoxic or ischemic injuries like in stroke or spinal cord injury. And really the overall primary risk factor for contracture development is going to be immobility. So spasticity is a risk factor for later development, but again, paralysis or that immobility is going to be the foremost risk factor. Contractures often worsen as a child goes through a growth spurt, and especially we see this in the adolescents as they go through that pubescent growth spurt, and often the skills that are lost during this time can be very difficult to be regained. So here you can see kind of the contracture cycle. So you start with loss of functioning, either from positioning or other neurologic sources. That's going to result in immobility, and then that immobility results in contracture. The contracture then is going to result in further loss of function, which will results in further immobility, and it continues to exacerbate and create new contractures, resulting in this cycle that continues to increase disability. So you can do radiologic studies like x-rays, bone scans, and other studies to be kind of discern the exacerbating pathology. You're looking for things like bony deformities, heterotopic ossification, fractures or dislocations, and you can also use MRI and diagnostic ultrasound that can be used to visualize the soft tissue structures. And so when I'm thinking about doing an exam on a joint that may have reduced range of motion, you're going to want to start with a slow, steady stretch, passively range that joint as far as I can without unnecessary force. You want to be careful as many patients can have osteopenia or osteoporosis, and they're at risk for fractures if you stretch them too aggressively. This slow, steady stretch is going to show what their available range of motion is, and understanding where their available range of motion stops is going to be really important as we think about grading spasticity, and we're going to be talking about that in just a few slides. So switching gears a little bit, we know that motion, and we just heard from Dr. Novacek, that motion is very complex. There's a lot of integrated different processes, and there's a lot of different neurological processes that are involved. So multiple different areas of brain centers, including cerebral cortex, basal ganglia, thalamus, cerebellum. There's the midbrain nuclei, there's spinal cord reflexes, and any abnormalities in that central nervous system centers can ultimately lead to motor impairments, and it can alter muscle tone, which usually then evolves into hypertonia. So hypertonia is somewhat of a generic term, and it's really encompasses all of the abnormal increase in muscle tone, and that's going to be caused by an injury or some type of dysmorphia in the central nervous system. So common dysmorphias that we see would be things like schizencephaly or holoprosencephaly. Common injuries would include things like hypoxic ischemic encephalopathy. You can get infectious encephalopathies. You can have stroke, trauma. You can have infants that are born premature, and you'll see germinal matrix bleeds into the periventricular area of the brain. And you can also see hypertonia in different types of genetic disorders, as well as in progressive neurologic diseases. So one that we think a lot about would be like the leukodystrophies. So I have listed here 5 common types of hypertonia. So spasticity, which would be the velocity-dependent resistance to muscle stretch. And we're going to talk a lot more about spasticity specifically coming up. Another common type of hypertonia is going to be dystonia, and that's really more of that sustained or intermittent muscle contractions. You can have chorea, which are that random incessant movements that have identifiable discrete patterns within them. You can have athetosis, which is more of a slow, constant kind of writhing movements. And then you can have bulismus, which is really that high amplitude movement of a limb, sort of where it shoots out in a really quick jerking motion. So the 2 most common forms of hypertonia in children are going to be spasticity and dystonia. So depending on the type of central nervous system injury, these hypertonia subtypes can occur either together or they can occur separately. So children with cerebral palsy commonly have both spasticity and dystonia, and they're going to have varying severity of each. So in general, non-ambulatory children with cerebral palsy almost always have at least some element of dystonia with or without spasticity. And in general, the severity of the hypertonia is going to be proportional to the severity of the neurologic impairments, which makes sense. So in addition to the hypertonia, the upper motor neuron abnormalities can lead to weakness, which would be the inability to generate kind of that normal muscle force. You can also lead to poor selective motor control, which would be sort of a difficult or poor ability to control the trajectory of a movement, and it can lead to things like apraxia, which would be the difficulty in learning or activating a complex motor activity. And so these different aspects of the motor disorders can further compromise the child's development and their motor function. And so looking more specifically at spasticity, so we know that spasticity is a motor disorder. We know that it's characterized by that velocity-dependent increase in tonic stretch reflex, and it results from an upper motor neuron lesion. So spasticity is going to present as either intermittent or sustained involuntary activation of muscles, and it's really this exaggerated velocity-dependent resistance to muscle stretch is what we're seeing and what we're defining as spasticity. So again, so what does that mean? What are we looking for? So again, that means spasticity is caused by an upper motor neuron lesion or problem, so something that's either brain or spinal cord based. And when you move the muscle fast, the muscle will sort of pull back and makes it harder to move through the range of motion. So this isn't something that the patient can control. It's an involuntary, sort of a reflex, we call it. So the greater resistance is felt when the joint is ranged with greater velocity. So the faster you move the joint, the more it's going to pull back. You can also see you can see things like increased deep tendon reflexes, you can see clonus, and you can see the emergence of more of the primitive reflexes. And so looking at kind of when we're checking reflexes and what we tend to see. So with a normal reflex arc, when you tap just below the kneecap, right? So you're trying to elicit that patellar reflex with the hammer, the sensory neurons are going to bring this signal from the periphery through the cell body of the sensory neuron to the dorsal root ganglion into the gray matter. And once it's in the gray matter, the signal is going to travel between the interneurons, and then it's going to be sent out the motor neuron, which is going to lead the quadriceps to contract and the hamstrings to relax, and you get that kicking motion of the patellar reflex. So it would be kind of what we would expect to see normally. So now if there's an upper motor neuron lesion, again, for something like cerebral palsy or a previous stroke, a brain injury, spinal cord injury, that's ultimately causing spasticity, there are going to be maladaptive neural changes. And so with spasticity, you lose the control, you lose that inhibitory portion of the descending reticulospinal tracts, and you're going to see an increased excitability of those inner neurons, which is going to lead to an increased stretch activated muscle spindles themselves. So the upper motor neuron lesion is what's going to change kind of that classic sensory motor reflex arc. And so when you move the limb fast, the stretched muscle is going to be activated abnormally. So you're going to have more activity or more excitability than you would expect. And that's what causes that velocity-dependent resistance. You're going to also see an abnormal increase in the patellar response. You're going to get a much brisker, rapid kick that's going to be more sort of aggressive or a bigger response than you would typically see without that upper motor neuron lesion. So the epidemiology of spasticity, or how common we see it, is really specific to the type and the severity of the central nervous system injury. For example, in patients with a spinal cord injury, we see spasticity in kind of 65 to 78%. In those with strokes, we see spasticity in approximately 17 to 39%. And in patients with cerebral palsy, more than 90% are going to present with spasticity, or at least some component of spasticity. Again, you can have multiple different types of hypertonia in the same patient. So at least 90% of patients with cerebral palsy are going to have some component of spasticity on their exam. And so then what we want to think about is, how do you identify this when you're actually doing the exam? So when I'm doing a neuro exam and I'm looking for spasticity, again, you need to start with that slow, steady stretch of the joint, because you're really trying to identify what's their available range of motion. I'm trying to identify any type of contracture formation, just like we previously discussed. And then I'm going to repeat that range of motion quickly. So I'm going to use velocity to try to elicit that catch and release if spasticity is present. So you're looking for a change in how much that muscle is pulling back as you change the rate or the velocity that you're moving that joint through its range of motion. And so if a joint doesn't have any spasticity, you're not going to feel any change in muscle resistance when moving through it. So it doesn't matter if you're moving that joint slow or fast, you're going to get the same range of motion, you're going to get the same kind of feeling of the muscle pulling back, which really is going to be minimal resistance. If there is spasticity, you're going to feel what we call a spastic catch, and then you're going to have, that's going to happen with increased velocity. And then once you feel that catch, the rest of the range of motion is still going to be harder to move that joint through. And again, you already know what the end range of motion is because you've ranged that joint slowly. So depending on where in that range of motion arc, the catch and the increased resistance is felt, it determines how we actually grade that spasticity. And we're going to talk about grading on the next slide. But it's important to note that with muscle weakness and with poor selective motor control, both being associated with central nervous system injuries, these often are proportional to spasticity. And so the bigger the injury, the more spasticity you tend to see, and the more difficulty you're going to see with weakness and poor selective motor control. And then it's important to note that spasticity does not vary significantly with arousal. So it can be exacerbated by noxious stimuli, but this isn't something that the patient is doing or inhibiting and isn't related to any sort of volitional portion of it. So spasticity is going to be typically graded using what we call the modified Ashworth scale, or the MAS score. And so the MAS, the modified Ashworth, is graded formally on kind of a 0 to 4 scale with 1+, but most often in the medical records, you're going to actually see it referred to as this 5-point scale. So those are the numbers that I have in parentheses. And that's because when you do research, the 1+ doesn't work when trying to do data collection. So we sort of switch the modified to be a 0 to 5. So an MAS of 0 means that there's no increase in muscle tone. So normal muscle would be an MAS of 0. So that would be no extra spasticity. That'd be what you would expect if you have no upper motor neuron lesion. An MAS of 1 out of 5 is where you're going to feel a catch and a release. An MAS of 2 out of 5, which is also known as that 1+, if you're using the 4-point scale, is going to be a catch, and you're going to have just a minimal increase in resistance through less than half of the available range of motion. So you're really paying attention to what's their full range of motion and where is that catch happening. And so an MAS of 3 out of 5 would be a catch, and then resistance through more than half the available range of motion. So you're having more trouble moving that joint through its available range. 4 out of 5 for MAS would be that it's difficult to move that joint through its entire range. So everything feels like you have that increased resistance. And 5 out of 5 would be a rigid joint that cannot be moved, or really a contracted joint. So a joint that doesn't move at all is going to be considered a 5 out of 5 for the MAS scale. So the range of motion of joints needs to be monitored over time, because spasticity is going to result in contractures unless it's treated appropriately. So you'd expect the range of motion to decrease and that contracture to form if we're not managing that spasticity appropriately. And then there's another way to measure spasticity that you'll see in some of our documentation, and that's using what's called the Tardo scale. And so that's going to define where in that arc of motion you actually feel that initial catch. So whatever degree you feel that catch in is going to be considered the R1, and the end range, so wherever the last sort of motion where that joint can range through, would be considered the R2. So a lot of times you'll see, a joint saying R190, R2 150, with an MAS of 3. So you're using both the Tardo scale and the modified Ashworth scale to determine what that muscle feels like, to get a better idea. And so the pattern of spasticity is going to depend on the location of the injury in the central nervous system. So here is the old images of the homunculus, right? So you can see the areas of the brain that control the different areas of the body. So of course, depending on where the injury, the abnormality is in the brain, is going to help you to determine where the spasticity presents in the body. So this is helpful because as you're doing an exam, if you don't have any imaging, or the diagnosis is still in question, you can get an idea of where you may expect to see abnormalities when you do a brain MRI. So just knowing that where there's injury is going to affect where you're seeing it on exam. And just like Dr. Vashik mentioned, there's different patterns. So you can have hemiparetic involvement, you can have diplegia, you can have quadriplegia. It just depends on kind of what that central nervous system injury looks like. And so then the clinical features and the presentation of spasticity are going to change over time. And this is based on when an injury occurs. So this is important to understand. So in the acute period following a central nervous system injury, you're often going to see that the trunk or the limb muscles that will ultimately be affected are flaccid. So you don't see any increase in spasticity early on. And so then as we move from the acute phase into that subacute phase, then this is when you're going to start seeing those reflexes becoming more brisk. They're going to be more exaggerated. And then you can start to see those increases in muscle tone and spasticity in whatever muscle groups are going to be affected. The progression of spasticity is variable between different disorders and between different individuals. But once you start to see the emergence of symptoms, it tends to be more progressive. And the subacute phase usually occurs within the first year after injury. And this is part of the reason that often infants, if they have cerebral palsy from some in utero or early delivery injury, aren't going to have high spasticity until closer to a year of age. And then we start moving into more of this chronic phase. So this chronic untreated spasticity is what can lead to those bony deformities like hip dysplasia that we've talked about in children with cerebral palsy. You can also see remodeling of soft tissues and muscles. You can see those soft tissue contractures develop, and that's going to ultimately limit their range of motion. And it's ultimately this remodeling that results in the postural and functional abnormalities. And so for hypotonia, including both spasticity and dystonia in children with cerebral palsy and any other neurologic condition, it can adversely impact their gross and fine motor skills. It can also impact their positioning, their care, their comfort. And so we treat spasticity with the goal to help improve their function, to help make those cares easier, to overall improve their positioning and their comfort. And really the goal of spasticity management is to reduce those maladaptive features to with the abnormal tone, basically to reduce that and to overall improve their function. The initial management really needs to focus on reducing any of the exacerbating causes. So we talked about any noxious stimuli can increase their spasticity. So we want to start by making sure we've reduced all of those that we can before you start considering specific treatment options. So most physicians and clinicians are going to do kind of a stepped approach to spasticity management, utilizing more benign strategies before resorting to treatments that carry a greater burden of risks or side effects. And then because spasticity can either be generalized, it can be focal or it can be multifocal, the different treatment strategies are going to be employed depending on what you're seeing. So the overall goal of hypertonia management is really, again, to improve that function. It's not merely just to reduce the muscle tone. So optimum and early management of hypertonia can help achieve developmental milestones. It can help improve their function. It can prevent contracture formation. It can improve a patient's tolerance of their braces. It can improve and help with their care, again, their comforting as well as their position. And it can actually help improve their weight gain velocity. So a lot of our patients have trouble gaining weight. The desired outcomes for a patient and why we would manage or treat their spasticity are going to be very patient and caregiver specific. There could be things that are very complex goals like improving mobility to more basic things like improving hygiene or decreasing pain. However, it's imperative to point out that not all spasticity needs to be treated. So spasticity can be useful for a patient. So a child can use their spasticity to their advantage. For example, a kid may use their spasticity to be able to stand or to take steps or to help them do stand pivot transfers. And if we treat the spasticity too aggressively, the child may actually lose the ability to do that. So anytime we're thinking about treatment of spasticity, we need to consider the function that they could lose as well as what they could gain through that management and talk through it to really try to achieve the best outcomes for that specific patient. And so there are lots of different ways to manage spasticity. When I think about treating spasticity, the way I talk about it with families is I think about it in terms of kind of three primary buckets: oral medications, injections, and surgical options. So stretching with basic range of motion activities remains the cornerstone for managing spasticity and preventing those complications, regardless of how else we decide to manage spasticity. So everybody needs therapies, bracing, stretching, and it needs to be incorporated into a home program. And really the goal with this is to prevent that contracture formation. So range of motion exercises are going to reduce spasticity because they decrease the input into that stretch receptor, right? So based on the limited evidence, we know that prolonged stretching is probably the most beneficial, which is why we use bracing and even stereocasting to achieve those prolonged stretches. We then use bracing to improve joint stability and to accommodate for any weakness. And bracing, of course, can also help with contracture prevention. will often use daytime and nighttime splints to help maintain their range of motion. So other than improving range of motion, physical therapy, occupational therapy, speech therapy may not significantly reduce spasticity, but with their focus on maximizing function, it's an integral part of management of children with spasticity. So in terms of the other buckets to manage to treat spasticity, it's really important to note that there is not a hierarchy. So you do not have to try and fail options from one bucket before going to the next. You can pick and choose from different buckets at different times based on what the specific patient in front of you needs. And so we're going to walk through these different treatment options in turn. So oral medications are commonly used to treat more systemic or diffuse spasticity in children. And, most oral medications that are used to treat spasticity are sort of generally have been poorly studied in both kids and adults. And we know that they can have side effects, especially things like sedation. So important is going to be to titrate up the dose slowly to kind of minimize some of those sedating side effects. And so the 4 medications that I think about and I talk about with managing spasticity is going to be Baclofen, dantrolene, tizanidine, and diazepam. So Baclofen is what I most commonly use, and it's where I almost always start. So it's a GABA B agonist, and it potentiates GABA. Baclofen acts at the spinal cord level, and it works to inhibit that monosynaptic reflex arc. Baclofen does not cross the blood-brain barrier very easily, so you have to use relatively higher doses to be effective. Baclofen can be sedating. It's one of the most common side effects, but this generally resolves after a few days or with a few doses at each of the different steps of their titration. And so with Baclofen, I counsel families, most importantly, that it can't just be stopped abruptly, but it would need to be weaned down and weaned off. Otherwise, you're going to end up seeing withdrawal symptoms, things like spasms, hallucinations, confusion. You can get seizures, you can get fever by stopping abruptly. And so dantrolene is another one. So dantrolene works to reduce the spasticity by inhibiting the calcium release, and that happens at this from the sarcoplasmic reticulum, and that's going to ultimately decrease that muscle contractility. Dantrolene tends to be less sedating than either diazepam or Baclofen, but the downside of dantrolene is that it has a hepatotoxicity rate of 1.8%. So almost 2% of patients are going to have some type of hepatotoxicity on this medication. That being said, the hepatotoxicity has not been reported in children less than 16 years of age. Sort of regardless of that, I always follow liver function tests closely. I'll check those prior to starting dantrolene and every 3 months while patients are on it. So it can be kind of a deterrent for using this medication in a pediatric population just because of those blood draw requirements. Tizanidine is going to be an alpha-2 agonist medication. Most common side effect with tizanidine is going to be sedation. And then the last one to talk about is diazepam. So diazepam is one of the oldest medications that's used to treat spasticity. It works by potentiating the effects of GABA in the central nervous system. And the primary downside of diazepam is that it can be very sedating, and it can cause things like impaired cognition, impaired memory, and then at higher doses, you can see respiratory depression. You can also see acute withdrawal from diazepam, and that can be very severe, so it would need to be tapered slowly over weeks to months. And so then injections are next. So then thinking through injections, the 2 primary that we talk about are going to be botulinum toxin injections, and there are 4 different brands. So Botox is one of the brands, and how botulinum toxin injections are commonly referred to as just Botox injections. The other 3 brands are going to be Dysport, Xeomin, and Myoblock, and the other injection option is Phenol. So botulinum toxin is an exotoxin. It's produced by the gram-positive anaerobic rod Clostridium botulinum, and it's going to block the release of acetylcholine at the neuromuscular junction, which is going to result in weakening of the muscle. When botulinum toxin is going to be injected into a muscle that's spastic, we know that tone is temporarily reduced. It has an onset after injection of about 1 to 3 days with a peak response by about 1 to 2 weeks and lasts for approximately 3 months. The studies have consistently shown a reduction in spasticity when you use botulinum toxins, and the dosing, dilution, and volume, localization, and procedural sedation that you're going to need to do these injections are really beyond the scope of today's discussion, but are very important when performing these injections. And so things to think about. And then in terms of safety, adverse effects are usually pretty mild and transient. Most often you would see pain at the injection site and localized weakness. Severe adverse reactions are uncommon, but when they are reported, they tend to occur more often in patients who are more medically complex, including those with cerebral palsy, those with a history of dysphagia, those with G-tubes, or have a history of aspiration pneumonia. And you can see systemic problems like fatigue. You can see generalized weakness. You can see respiratory problems, incontinence, and dysphagia. And there are rare reports of really excessive weakness and even death. And so the FDA did place a black box warning on the botulinum toxins in April of 2009. So I counsel all patients and families about these risks with every single time I plan for injections. Phenol is an alcohol. It has a hydroxyl group bonded to the benzene ring. It has strong proteolytic properties. And so when you're using phenol in concentrations of about 5 to 7%, you're going to get denaturing of protein and tissue necrosis. And so when this phenol is injected onto a motor neuron, you're going to cause a chemical neurolysis, and you're going to effectively denervate the muscle that leads to then a reduction of spasticity. And that's because you're decreasing both the efferent input into the muscle and you're decreasing the afferent impulses from the muscle spindle. Phenol blocks are nice because they have an almost immediate onset and they are somewhat temporary, lasting approximately 4 to 12 months. Phenol does not readily diffuse in tissue, so localization is critical and usually involves either ultrasound or electrostimulation. Again, dosing, detailed localization, and procedural sedation for phenol are beyond today's discussion, but would be important when performing those injections. Most common side effect of phenol is going to be dysesthesia. So if it's injected onto a sensory nerve, you can have sort of that numbness, tingling, or dysesthesia side effect from it. Phenol can also have more permanent effects if you inject the same nerve over and over, or you can actually see diminishing effect over time because localization of the localizing of that nerve can become increasingly difficult as the nerve's responsiveness to the electrostimulation diminishes as you accumulate scar tissue with repeated injections. And you can use both phenol and botulinum toxin on a patient, targeting different muscle groups. So they can be used together. And then lastly, we'll briefly discuss 2 surgical options in spasticity management. First will be intrathecal Baclofen pumps, and the second will be a selective dorsal rhizotomy, or SDR. There are a few other surgical options like a ventral dorsal rhizotomy or a non-selective dorsal rhizotomy, deep brain stimulation, and other orthopedic surgeries, but we won't address those specifically today. So we already discussed that Baclofen, when taken orally, is a neuroinhibitory of the monosynaptic reflex at the spinal cord level, but that it poorly crosses the blood-brain barrier. So the intrathecal Baclofen pump allows a more direct delivery of the medication to the target sites, and it allows about 1/1000th of the oral dose, since it bypasses that blood-brain barrier altogether. Baclofen pumps can be used to treat both spasticity and dystonia, and the pump itself is implanted subcutaneously in the abdomen. Most often you'll see it in the right lower quadrant. The catheter is then passed below the skin from the pump around the side to the lumbar vertebral interspace, and the catheter is then passed into the intrathecal space. The pump is then programmed to deliver different doses of Baclofen at different times with the goal of optimizing the spasticity management for the patient. So each patient with a pump is going to have a unique program, and the pump needs to be refilled with medication every few months. And the frequency of the refills is going to be dependent on the dose. And these are done in clinics. You can do single needle through the abdomen right into the pump to refill it. And then the pump itself must be surgically replaced for battery life every about 5 to 7 years. There are complications associated with the pumps, including infection, catheter problems, CSF leaks, and you can very rarely see pump failure. But acute Baclofen withdrawal is going to be the most life-threatening and needs to be addressed immediately if you're concerned with a patient with an intrathecal Baclofen pump. And then selective dorsal rhizotomy, or SDR, is where the sensory or the dorsal rootlets are going to be stimulated and cut. And so it works to decrease spasticity because you're going to disinhibit the monosynaptic reflex arc, and so that is disrupted. So where that cycle is just sort of going through because it's overly excited, you're going to disrupt that. And so by only cutting the sensory fibers and cutting about 25 to 60% of those, you can reduce spasticity and you can preserve movement because we're not cutting any of the motor fibers. Those are all left intact. So SDR is completed in the lumbar area, tends to be dorsal roots of L1 through S1, S2. They're accessed through a laminectomy, either at the conus medullaris or at the cauda equina. The roots are divided into rootlets. They're electrically stimulated, and those with the abnormal responses are cut. So the ideal candidate for an SDR would be a child, typically ages of kind of 4 to 10, would have spastic diplegic cerebral palsy, secondary to periventricular leukomalacia, so those early bleeds and having that periventricular injury. It would be a child who's ambulatory, but who has significant lower extremity spasticity, but who would have minimal or no dystonia. And then following SDR, children are going to require very high intensive therapies to really maximize their benefit, because you're going to see the underlying weakness come through when you reduce that spasticity through the surgery. And so as you can see, there are many different ways to manage spasticity. Each patient is going to have a different management plan based on their unique needs and goals. And these can be different at different times throughout a child's life.